Hi all. Today we'll be discussing on a practical approach to syncope. What is syncope? Syncoptein means cut short. Their consciousness has been cut short. So, a syncope is abrupt and transient loss of consciousness. Note that this is transient, associated with loss of postural tone, followed by a rapid recovery, and rapid recovery being the key of a benign syncope. The basic pathophysiology is hypoperfusion of brain. What are the causes of syncope? Broadly, if you see in our practice, we want to know whether it's a benign or an autonomic syncope versus a pathological cardiac or a neurological cause of loss of consciousness. Cardiac syncope can be broadly classified as due to arrhythmias, outlet obstruction and coronary events. Autonomic syncopes, common one is neurocardiogenic syncope, and the pathophysiology behind it is a paradoxical reflex called as Bizold-Jarisch reflex, where there is peripheral pooling of blood associated with bradycardia rather than a tachycardia. A syncope or a neurocardiogenic syncope generally has a background precipitating factor that can be decreased sleep, decreased water as in dehydration, decreased food, hypoglycemia, decreased blood, anemia, plus or minus a viral infection background. In the phase of precipitating factor, if the patient is also meeting with a triggering factor like prolonged standing, like in assemblies, sudden change in posture from sitting to standing, or an emotional stress, that can result in a neurocardiogenic syncope. This neurocardiogenic syncope has generally three phases. A prodromal phase where the patient experiences dizziness, nausea, warmth, sweating, visual changes like a tunnel vision, muffled hearing, and the bystanders might observe a pallor just before loss of consciousness. This prodrome in different combinations follows, or rather this prodromal phase is followed by a loss of consciousness, which is followed by complete recovery, which is almost always instantaneous. So, you have five components in a neurocardiogenic syncope. You have a precipitating factor, you have a triggering factor, you have a prodrome, loss of consciousness followed by a complete recovery. So, why does this neurocardiogenic syncope happen? Prolonged standing or sudden change in posture results in venous pooling. So, when the blood is pooled in the periphery, there is going to be decreased venous return resulting in decreased preload. Decreased preload means decreased cardiac output, which means there is going to be activation of arterial baroreceptors. This results in increased catecholamines. Okay, this is not decreased, this is increased catecholamines, resulting in rapid contraction of heart. But you are just putting motor to a empty tank because there is decreased preload. So, there is rapid contraction of an empty heart. On the other hand, decreased preload can also result in activation of mechanoreceptors, cardiac mechanoreceptors, which results in activation of vagal nucleus, resulting in bradycardia in the face of a decreased preload. Both of them ultimately resulting in decreased perfusion to brain, ending up in syncope. So, what's the importance for us? The importance for us here is to elicit the precipitating factors, the triggering factors, what happened during the episode, previous to the episode, after the episode, so that you can clearly differentiate a neurocardiogenic syncope or a vasovagal syncope from that of a cardiogenic or a neurogenic syncope. The important points in history that you need to assess are these: the time of event, the activity which led up to the event, associated symptoms during the event and just prior, posture at the time of onset, and family history. Each of them carries a significance. Suppose this event has happened during morning assembly. After prolonged standing, the child has faced some sweating, some tunnel vision. Posture was standing during the time, and there was no family history. All of these might suggest a classical neurocardiogenic or a vasovagal syncope. Correct? Hence, a detailed history is the single most important diagnostic factor for you to say this is a benign syncope or a vasovagal syncope. Always remember, syncope in a supine position is never benign. Never ever label a patient who experiences syncope in supine position as having had a vasovagal syncope. It needs to be evaluated. Cardiac causes needs to be ruled out. That brings us to our next cause of syncope, which is cardiac syncope. The classical feature of any cardiac syncope is usually syncope at the height of exertion. If you compare with that of the vasovagal syncope, it did not have exertion as an important component, whereas for a cardiac syncope, exertion is a very, very important component. As we discussed earlier, it can be broadly classified as an outflow obstruction, arrhythmia or coronary event, ultimately resulting in hypoperfusion of brain. Outflow obstruction can be of right or left sided, does not matter. This outlet obstruction, RVOT or LVOT, is a fixed obstruction. So it is okay during resting states, but while exertion, this outlet obstruction will impede the amount of cardiac output that is going to get out of the heart, resulting in syncope. Arrhythmias can be of multiple varieties. You will generally have a family history that you need to elicit. Family history may not straight away state that, yeah, my cousin had this arrhythmia. It might be in the form of a sudden unexpected death in the family. Death at a younger age where the cause was not known. Death while traveling in a two-wheeler, alone motor vehicle accident where there was no cause for the motor vehicle to end up in an accident. So you get my point. So sudden unexpected death, unexpected being the key word here. Multiple types of arrhythmias are possible. Long QT syndrome, Brugada syndrome especially needs to be suspected whenever a febrile child is having multiple syncopal episodes. Wolff-Parkinson-White syndrome, catecholaminergic polymorphic ventricular tachycardia. Coronary events, see, Kawasaki disease is fast becoming one of the most common heart diseases or acquired heart diseases, that's replacing your rheumatic heart disease. If there's a past history of Kawasaki disease, you should think of coronary events resulting in a syncope, or abnormal left coronary artery arising from pulmonary artery or an abnormal location in aorta. So those can also result in a syncope. Alcapa usually presents in younger age groups, infancy like heart failure, and in older age groups like chest pain and syncope, which is going to simulate a myocardial infarction. So always remember, syncope without prodrome with exertion is cardiac syncope unless proven otherwise, and you need to rule out cardiac syncope with history, examination and your ECG. So that brings us to neurogenic syncope. Neurogenic syncope, by that I mean a seizure. Seizure may be mistaken for a syncope, because see, even in a syncope, convulsive movements are possible. So how do you differentiate a convulsive movement at the end of a neurocardiogenic syncope with that of an actual true seizure? So if you elicit the history, you will be seeing that there is a prodromal and a presyncopal phase in neurocardiogenic syncope versus nothing in actual seizures. Tongue bite rarely happens in a syncope, and if at all, it's going to be at the tip of tongue. Whereas in seizures, tongue bites do happen, and if at all it happens, it's going to be on the sides of tongue. There is no incontinence in syncopal movements, whereas incontinence can be there in seizures. The movements are pleomorphic, where you are not able to characterize exactly how the movements were. Whereas in a seizure, it's usually rhythmic and uniform, and it can be reenacted by bystanders who had seen the event. The duration is less than 1 minute in a syncopal movement, whereas it's more than 1 minute in a seizure. The fatigue is the most common postictal phenomenon, so-called postictal phenomenon in syncopal, whereas in seizures, usually during the postictal period, the patient is confused rather than fatigued. So with all this in mind, what are the examination points that you are going to concentrate on when a patient is going to present to you with syncope? For the vitals, your basic heart rate, respiratory rate, yes, but what is it that you are going to concentrate on? If the heart rate is going to be very low, you should think of a heart block. If the pulse volume is low, then you should think of a outlet obstruction, left ventricular outlet obstruction. Suppose blood pressure is different while lying down and standing up, and while standing up it's going to fall significantly, think of a postural hypotension. SpO2 can give clue to underlying congenital heart disease like tetralogy of Fallot associated with pulmonary hypertension. Cardiovascular system examination, whenever you find a ejection systolic murmur in second intercostal space, always think of outflow obstruction depending upon where you see. If in aortic area you see ESM, then think of that side outlet obstruction. Parasternal heave is suggestive of right ventricular hypertrophy, which is indirectly suggestive of pulmonary hypertension. Loud P2 is suggestive of pulmonary hypertension. Neurological examination is for us to know whether the patient had indeed had a seizure rather than a syncope. If you are suspecting seizures, look for the cause of seizures. Look out for neurocutaneous markers. See if the patient has signs of raised ICP. See if the patient has post-seizure focal neurological deficits. So that will give you a clue that this was not a simple syncope but was indeed a seizure. Investigations wise, ECG needs to be done, especially in patients where you are not able to rule out a neurocardiogenic syncope or a vasovagal syncope. Or if you think the semiology is atypical and you are not sure enough, then do a ECG. So to put all of this in a small flow chart, which is taken from Canadian Society for Pediatric Cardiology guidelines for approach to syncope. If the patient is presenting with a syncope, return to baseline at time of assessment. Any of the following: if the patient had had a mid-exertional syncope, abnormal cardiac physical exam, history of arrhythmias or structural heart disease, family history of unexpected death, then ECG and a pediatric cardiology referral is a must. Suppose these are not there and you find that there is no prodrome either, then see if there is a motor activity that precedes the loss of consciousness. If the motor activity is suggestive of a seizure, then consider a seizure workup. If not, then still think of a cardiac cause because there was no prodrome. Suppose prodrome was present, but there was a prolonged loss of consciousness or this episode happened in a supine position. You should consider a seizure workup. If these are also not there, then the presentation is consistent with vasovagal syncope and no further investigations are required. No further investigation as in no ECG, no EEG, no neuroimaging. So for a typical vasovagal syncope, what are you going to advise? You are going to advise the patient on education, good sleep, adequate sleep, proper food habits, lifestyle modifications if necessary, decrease the provoking factors, increase salt and fluid intake up to 1.5 to 2.5 liters of water per day and 2 to 5 grams of salt per day. Physical preventive and rescue strategies have been shown to decrease the incidence of syncope in adults that pediatric studies are lacking, but I don't see any reason why it should not work for pediatric population also, and this is being widely practiced as a safe advice. If the patient has to stand for a long time, you can ask them to squat in between. You can advise them buttock clenching while they are standing or a leg crossing so that the decreased peripheral pooling happens rather than increased peripheral pooling. If these conservative managements are going to fail, if the syncope is refractory but still vasovagal, midodrine may be tried. So in conclusion, syncope is a common cause of visit to pediatric OP practice and emergency department. If there is an abnormal family history, syncope during exercise, abnormal physical and abnormal ECG, it is cardiac syncope and never consider a vasovagal syncope. The most important point for you to differentiate the different types of syncope is history and physical examination rather than investigations. Investigations are not high yielding. And you should never consider a neurocardiogenic syncope if the patient had had a syncopal episode in supine position. These are my references: IJPP January-March 2020. This is available for free in IJPP website. Canadian Cardiovascular Society Approach to Syncope and Moodley et al.'s Clinical Approach to Syncope from Seminars in Pediatric Neurology. Thank you for listening to me patiently. Hope this was helpful to you for theory as well as your pediatric practice. Share this among your colleagues if you found this informative. Thank you all. Bye bye and all the best.